So we'll go ahead and get started. So, what's up your butt? All right. So a friend sent this to me last year after I did a surgery on her father for colon cancer. And many of you may not know it is Colon Cancer Awareness Month. We all hear about breast cancer awareness in October. They have better marketing, I guess. But it is Colon Cancer Awareness Month. It's something we should be aware of throughout the year. But this is a good time for this talk. So what is your colon? Colon is the large intestine. You probably heard that. It's the last part of your GI tract. It's about 5 feet for most people, somewhere between 4 and 6, but about 5 feet for most people, which can surprise some people that you have that much room in there. It starts, so on the left side of your screen, which is the right side of a person, if you're facing them, this is the first part of your colon. All this is small intestine. It enters in something called the cecum. It kind of frames out your abdomen here. So then stool moves up and over and down, and then down to the rectum and on out. So you've got cecum, ascending colon, transverse colon, descending colon, sigmoid. It's called sigmoid because it's kind of S-shaped. This picture doesn't really do it justice. Most people, it'll come way up there and down. That's where a lot of times when you're feeling things, that's often where you're feeling it. That's where the stool gets the hardest. By the time it moves around there, there's some tight turns. That's where usually when you're getting a colonoscopy, if your physician has any trouble, it's often right in there moving through it. So what does your colon do? Primarily makes solid waste. So it produces and eliminates solid waste. It absorbs water. Everything, when you eat this solid food, it mixes with a bunch of secretions in your mouth to start with saliva. There are a few enzymes there. It moves down, stomach acid, and a few enzymes, and then moves on in your small intestine. Small intestine is where all the digestion and absorption takes place. That's where you get all the bulk of your nutrition, as far as absorbing carbohydrates and proteins and fats and that sort of thing. And then what enters your colon is liquid, so a bunch of liquid. And then as it moves through, it becomes more solid. How solid your stool is primarily depends on rate of movement through your colon. The longer it's in there, the more water gets absorbed. There's some other things that can affect it too, inflammatory changes, infections, and that sort of thing. But a lot of it has to do with how much water reaches it. So there is some absorption of some vitamins. Vitamin K is a common one. Anybody taking a blood thinner called cumin and warfarin may be familiar with this, dietary restrictions and things. Vitamin K is important for making some of the clotting proteins that your liver does. So a lot of absorption occurs in your colon from that, and thiamine and riboflavin also. Fermentation occurs in your colon. The colon is where there's bacteria. There's no normal bacteria in your stomach and not really any in your small intestine. In your colon, there's over 700 species of bacteria. There's trillions of bacteria in your colon. And they're very important. Most of them are normal. They're called commensal. So without those normal bacteria in the appropriate amounts, you can have some functional issues. So the bacteria actually are important for absorbing some of these things. Also, they break down some of the starches and some of the complex carbohydrates, and you can absorb some. They're actually very important for feeding or the nutrition of the cells that line your colon too, the mucosa. They create some products that are absorbed that are important for healthy function of your colon. And that's where your gas comes from. People ask all the time about why they have so much gas. Why does it smell like it does? Of course, the food you eat is important because these bacteria break down certain things and make different chemicals that provide the smell. But if you're having a lot of gas, that's not always a bad thing. That means you probably have healthy gut bacteria or healthy GI bacteria. Not a pill for it. So what is healthy bowel function? It's pretty broad. A lot of people think they have to have a bowel movement every day. You don't. Some people do. A lot of people do. A lot of people have more than one. Some people less frequent. So it really, in general, is stool that is neither unusually hard or soft, and it should pass without overly hard or painful straining. So that leaves a pretty broad spectrum there. This is called the Bristol stool chart. People will make a chart for anything or classification scheme. I heard about this several years ago. I can't remember what. I had a nurse call me and was telling me about a patient's stool, and they told me a type on the Bristol stool chart. And what the heck are you talking about? Is it soft? Is it hard? Is it loose? Well, anyway, this is what it is. Type 1 would be basically hard lumps, hard to pass. This is a little harder, but more formed, all the way down to the diarrhea, watering. In general, you want to be somewhere in here. Type 4 is, they put it right in the middle because that's probably just about perfect, but it's not going to be that all the time. It can vary, but if you stay in 3 to 5, you're probably okay. The frequency, highly variable, depends on age, your activity level, diet. Those are all the big things, and of course medications can affect all that. There's some things that slow it down. Probably the biggest thing that everybody hears about are narcotics, pain medication. They all throughout your GI tract, not just the colon, but they just slow down how it moves. And then there's a lot of other medications too, although diarrhea is probably a more common problem than constipation as far as most medications. But if you read the package inserts, it'll say diarrhea or constipation, abdominal pain, bloating, gas. So a lot of medications. In general, less than 3 bowel movements per week is considered abnormal. That's considered constipation. That's the definition. Now it can vary with the person. If you're having a bowel movement every other day, but you have to strain every time and it hurts, then you're constipated, even if you don't meet that definition. In general, more than 3 bowel movements per day is generally considered abnormal also, so that's probably a little too frequent. Although if they're pretty well formed and you've been like that for a long time and it's not a recent change, that's probably okay too. We worry more about changes. If you have a change suddenly or over a short period of time, you may need to talk to somebody about it because see what's causing it. Whether it's sometimes a diet change, but a functional change, some sort of disease process, or medication that you're taking. Color. Color is important, but not that important. It's mostly due to the bile. So your liver makes bile. It's excreted into the first part of your intestine, small intestine, just past the stomach. Bile gets rid of waste products. It binds to fat that you eat and helps you digest and absorb all that. Bile is kind of amber to green color. As it moves through, it turns brown. That's what gives most of the color. Even with all the food you eat, the color doesn't usually come from your food. Certain food colorings and things as it moves through, you may come out like that or if it moves through too fast, but most of the colors due to the bile. Any shade of brown and green. People will have bright green stools sometimes. Usually it's going to be more on the softer, loose side. That's still the bile. That's still okay if it happens every now and again. If you have more yellow, like really bright yellow, and it's kind of loose, then that can be abnormal. It can indicate possible without malabsorption, so things aren't getting absorbed and broken down right. That's usually going to be fat if it looks like that, and people tend to have loose stools after eating higher fat foods in that case. If it's red or black, that can be blood, so bright red can be blood, black can be blood too. Some of y'all may have experienced that or heard of that. That's as it moves through, it'll get broken down and turn black. So black and foul smelling, maybe tarry if you've heard that. You need to check with somebody, check with your doctor about that if you're experiencing it. Light or clay colored, that's the real problem. So if it gets light or clay colored, that means there's not bile getting into it, because if you remember, the color comes mostly from bile. So if there's decreased bile flow, typically it's going to be a blockage from your liver or something like that. It can be benign and non-benign processes that do it, but if you start experiencing that, get it checked out. We'll talk a little bit about diverticulosis. That's probably the most common thing that most of us have going on with our colon, other than just functional issues. So diverticulosis, you may have heard of diverticulitis. They're related, but diverticulosis is having these little pits or potholes. This is a view from a scope, from a colonoscopy. This is what they look like. From the outside, they look like little bubbles. Little balloons or outpouchings on the outside of your colon. It affects over half of Americans over age 60. So most of us are going to get it. Over age 80, almost everybody has it. And it's just a function of pressure, and time. So there's pressure in your colon, and over time that pressure causes these little weak areas that will bulge out. We see it more in people that are constipated. We see it more in people that have longer colons. We see it more in people that are taking laxatives chronically and that sort of thing. But in general, everybody's going to get it. And then complications, that's what diverticulitis is. That's a problem, having those. If your doctor says you have diverticulosis, they see it on a colonoscopy or on a CT scan, a CAT scan, some x-rays, We can see them there. If they tell you that, that doesn't mean you have diverticulitis. It doesn't mean there's a problem. It doesn't mean you're going to get diverticulitis, but you can. So that's inflammation or infection. You add itis to the end of everything, that means inflammation. Symptoms, primarily pain, sometimes bleeding, sometimes fever in worst cases, but pain is going to be the biggest thing. You can have, some people have diarrhea, some people can get constipated because they get a swollen area and stuff doesn't pass as well. But typically also the pain is going to be on the left side, down low where that sigmoid, the S-shaped colon is. So anybody that's had appendicitis will often say it feels like appendicitis on the wrong side. Typically it's going to be treated with antibiotics. Typically just antibiotics alone. Sometimes outpatient. If it's mild, you just have pain. Sometimes it's clinically diagnosed. If you've got the pain in the right spot and you have the risk factors and treat it with antibiotics, if it gets better, it's good. If it's more severe, you may get a CAT scan and that can show swelling or inflammation. If it's really severe, a lot of people end up in the emergency room and we do some imaging and blood work. And so in severe or perforated, they can rupture or perforate. And basically that means there's a leak in the wall of the colon. That may require surgery, sometimes emergency surgery. Sometimes your body is amazing. It does a good job of walling it off, and sometimes it'll still get better with antibiotics. But in those cases, you may need some other procedures, and you may need some further testing to make sure it was just an infection. So surgery is usually reserved for these severe cases or repeated bouts. If you have it over and over, even if they're not severe cases, but it's happening fairly frequently, and the recommendations are changing. Used to, we'd say if you've had 2 bouts of it, particularly 2 bouts to get you in the hospital for antibiotics, you should consider having surgery to remove that bad section of the colon. More recently, in the last several years, that position's been changing. There's data showing that having 2 cases doesn't mean you're necessarily going to have a lot more frequent, and it doesn't mean you're necessarily going to have a perforated case. So surgery is getting pushed farther and farther out, and that's a good thing for most people. I'm a surgeon. I do those surgeries. I like doing them, but if you don't need it, I don't think we need to do it to you. So, but sometimes if you have infection over and over, scar tissue can form, stricture, obstruction. That's when you start having bowel function changes. That's when you start having progressively worsening constipation. You start having less frequent bowel movements and they get smaller in size, and you need to ask your doctor about that and see if you need some other testing. And then the other common complication of diverticulosis is bleeding. Typically it's going to be bright red blood. They dump a lot of it. A lot of times it gets people to the emergency room because of the amount, and they may get symptoms from it: dizziness, lightheadedness, low blood pressure. But it is the most common cause of major rectal bleeding. Now, some people will have black stools off and on, minor bleeding. That can be any number of things. But for major bleeding, people over 40 is the most common cause. But usually it stops without it doing anything. If you're on blood thinners, you stop those. If you're not, give it a little time. Use a little vessel, bleeds a lot, then it heals up, just like on your skin. Things can clot and stop. But you may require colonoscopy to look and sometimes to stop bleeding if it's ongoing, or in rare cases, surgery. You may be following some diet restrictions: nuts, seeds, popcorn, corn, all that. Well, there's no evidence to support that you need to avoid all those things. And we've known that for a little while now. It just takes a while for that information to get disseminated. And a lot of times people have had diverticulitis off and on for a long time, and they found certain foods like that do seem to cause them trouble. If that's the case for you, avoid the foods that cause you problems. If you're having bleeding every time you eat popcorn, don't eat popcorn. If you have pain or something like that. But in general, you don't have to avoid the nuts, seeds, popcorn, so you can eat your tomatoes when they're in season. I hear that a lot. You mean I can't eat tomatoes now? No, you can. It's all right. And in fact, some of the things that we used to eliminate if you had diverticulosis were nuts and seeds and some fruits like strawberries and things. Those are actually good sources of fiber, which is the one thing that's been shown to decrease your risk of having problems from diverticulosis. A high fiber diet decreases your risk of infection and bleeding. And you're going to see as we go through, that's the one common thing throughout all these problems is fiber. So high fiber diet is the key to your colon health, and so these are some of the things. So fruits and vegetables, whole grains. If you're avoiding carbs, you still have some options. Nuts and seeds that are high in fiber. In general, it's recommended. So we'll talk a little bit about things to help you go, and then I'll talk a little bit about things to slow you down. These are most common, stool softeners and laxatives. Normally, most people are taking a pill to help them go more regularly. So there's lubricant laxatives, things like mineral oil. I don't know how many people take these now. They're rarely really prescribed. Most times, just like when I was a kid, my grandmother gave me mineral oil all the time. I never take it. I've never had any of my children take it. And I'm probably biased. But anyway, it's basically, you can have long term if you're taking this to keep you going. It basically just lubricates, lubricates your GI tract so things run out. It's a fat. But you can have fat-soluble vitamin deficiencies with prolonged use. It binds, there are certain types of vitamins in your diet, A, D, E, and K, that bind to fat, and that's necessary to be absorbed. If you're taking too much of this, it can cause those to be excreted, comes on out in your stool without adequate absorption. So you could have some deficiencies, but that's really chronic long-term use. Stool softeners, this is the most commonly thing used. DocuSave or over the counter, it'll just say stool softeners on the bottle. It's used all the time. We recommend it when you're taking pain medication or something to help keep things regular. For a lot of people, it does work. There's very few side effects, so it's thought to be safe for use daily. But the studies actually show there's not really any improvement when you look at studies, and these are groups of people, not individuals. Really no improvement in stool frequency or the water content. And they determine that by weighing stools. People that are taking them and not taking them or doing other types of diets. That is primarily compared to fiber, though. If you're getting adequate fiber in your diet, probably don't need a stool softener. But a lot of people go right to a stool softener before really addressing the fiber issue. So compared to fiber, stool softeners like DocuSave don't really do a whole lot. Polyethylene glycol, which is what Miralax is, and that's over the counter in generic forms these days. It's an osmotic laxative. It just increases the water content. It holds more water and causes excretion of water. So the more water, the looser things are going to be, and the better you go. It is thought to be relatively safe for extended use. So if you need to do it daily for a while, that's okay. If it's working for you and you've increased your water intake and your fiber intake and all that sort of thing, then you can take it, and then I usually recommend people start weaning off of it over time. But some people do have to take it long term. If you've done all the other things and you've ruled out some cause of, like a blockage or growth, cancer for sure, and you still are having bowel function problems, it's dysfunctional, and Miralax works for you, it's okay to take routinely. But make sure your doctor knows that you're taking it, and that there's appropriate follow-up. And then things called stimulant laxatives would be like Docalax, Senecot, those sorts of things. X-Lax has Sena in it. Those stimulate contractions. These other things just soften, keep water in, fiber bulks the stool, and that's how they work to help move things through. The stimulant laxatives cause contraction. They make your GI tract pump and contract to push it out. They cause more cramping, more association with diarrhea. Those are the ones, anything can make your colon kind of dependent, but these are the worst offenders. The laxative dependence, after a while your functioning of your colon gets worse and worse, and you can have long-term problems with dilated colon. For antidiarrheals, there's a few of them, the most common ones. Well anyway, first, they're really not for prolonged use. You don't want to, because if you're having persistent chronic diarrhea, there's usually a reason. Now it may be irritable bowel syndrome, but you need to get a physician consultation, determine the cause of those symptoms before it's determined that it's something that you can just treat the symptoms for. Because all these do is treat a symptom without treating a cause. So Pepto-Bismol, that's one that's over the counter. Imodium, that works better than this. That's loperamide. That's also over the counter. Lomodal, those all they basically slow down the function of the GI tract. Sort of in a way temporarily paralyze it so you have less diarrhea. Slow things down, more water gets absorbed, and your stools are more solid. They also should only be used occasionally, like I said, and for non-infectious diarrhea. One of the more common causes of diarrhea is infection somewhere in your GI tract. It may be your colon, like a colitis or a diverticulitis, but also viral infections in your small intestine, your stomach commonly cause diarrhea. You don't want to take these if you've got an infectious cause, because It can actually cause retention. When you're having diarrhea, your body is getting rid of the cause of the infection or the toxins that's being produced that's causing the inflammation. And if you slow things down, it sits in there longer, it can worsen the process. And that's particularly the case with C. difficile colitis or pseudomembranous colitis, C. diff. That one, definitely, if you've had a history of taking antibiotics for some reason, or if you've been in the hospital, and you develop profuse watery diarrhea with abdominal pain, sometimes blood, sometimes fever, you need to talk to your daughter or doctor. If your daughter's a doctor, that's okay. But talk to your doctor before you take any of these things, because you can make it worse, a lot worse, and require hospitalization, even require emergency surgery. So. Okay, colorectal cancer. This is kind of really why we're here today. This is a terrible picture, and I put it up there for its shock value. We don't ever want to see this, and I do see it sometimes, and that's one that when we're doing, this is on a colonoscopy, anytime you see this kind of round picture, that's what we're looking through a scope. This is on the inside of your colon. This is a bad one. We call it circumferential, all the way around. It's probably partially blocking off. There may be the opening there. When I'm doing colonoscopies, come around a corner or a fold and you see this, everybody in the room goes, oh, because that's advanced. And they don't have to get like that. And I'll tell you how as we go through this. But colorectal cancer, it is the second leading cause of cancer-related deaths. That's not incidence. That's cancer-related deaths in men and women combined. So as far as cancers go, second leading cause of cancer-related death in men and women. So it's common and it can be bad. There's a 5% lifetime risk of developing colon cancer for the average person, about 5 Americans at least. Or that's about 1 in 20 people are going to get it. So it's pretty common. Symptoms can include bleeding, that's what that was doing, a change in bowel habits, you'll have that with this one, and pain, but they're usually absent. You don't have any of those symptoms until they get closer to this. I mean, they'll do it before that probably. And of those, probably bleeding would be the earliest one and most common. But again, for years, these things don't have any symptoms until they get worse. And once you have symptoms, then we're doing scopes and tests to try to figure out what's causing those symptoms and hope it's not this. So the incidence of colon cancer, actually, even with these numbers being pretty high, the incidence has been decreasing since the 2000s. And that's due to early detection. And so how does it start? How do you get to this? I mean, that didn't happen overnight. Okay, so they start like that. Looks benign, and it is. Benign meaning not scary, not harmful, and that's a benign adenoma, which is a fancy term for a type of tumor or growth, but not a cancer. So this is how they start, actually even smaller than that. It's one cell undergoes, and we know what the genetic changes are, but there's certain genetic or DNA mutations or changes that have to occur for a cell to start growing abnormally, and then it gets bigger and bigger, and as they get bigger, they can then undergo further changes to turn into cancer. So it's kind of small, but adenoma, CRC is colorectal carcinoma, starts like that. They get bigger and bigger. These are all benign. You can get something called dysplasia, which is some early precancer changes, and then it starts growing like this, and then the other one, the one you saw in that picture was more like this. First, the cancer starts in this polyp that's sticking out, and then this part becomes cancer, and then that starts growing in through the wall of the colon. And so you want to find them down here somewhere, as early here as possible before they get up to here. And this says 10 years. That's about average. It takes 5 to 15 years. About average is 10 years to go from this to that other one. So you've got a little time. But the bulk of that 10 years, you don't know they're there, they don't have any symptoms, which is why we need to look for them. Now's the time to do it, you know. So, what are the risk factors for colon cancer? Age, that's our biggest risk factor. It's like that with pretty much with most cancers that aren't congenital or some genetic thing you're born with, but age is your biggest risk factor. 90% of colorectal cancers occur over the age of 50, and the bulk of those are going to be over the age of 60. They can happen earlier than that, particularly with certain familial disorders, but even sporadically or just randomly, they can happen earlier than that. but it's uncommon. So we don't recommend testing people or doing colonoscopies on people, when they're 15 or 20, because we're just not going to put people at risk without finding things. But at age 50 and over, your risk is high enough where it's worth getting checked in some way. And there's a few ways we'll talk about. So family history increases your risk, particularly if it's a first-degree relative, a parent, a sibling, brother or sister, and a child that's had colon cancer. That increases your risk. So typically your recommendations are going to be sooner and more frequent. Even family member with polyps, the problem with this is getting this history. A lot of people don't know if they're, even if their father had polyps on a colonoscopy at, age 70, So we don't always know this, but typically if somebody close to you in your family has a colon cancer, most people hear about that. Males get it more frequently than women. Not a lot more, but enough to make that as a risk factor. African Americans is a little more common too. About 20% higher incidence than Caucasians at least. Diet is a risk factor. So hey, there's fiber again. Low fiber diet increases your risk of getting a colon cancer. So, fiber really, but if you take anything, and I'll do in the summary, but I'll say it now too, you take anything away from this, eat a high fiber diet, or just pick one you can take. Go look at that wall and say, I think I can take that capsule or put that powder in my coffee or something, and just do it every day to help decrease your risk. It doesn't eliminate it, but it decreases your risk. So low fiber and a high fat diet increases your risk. Red meat, nobody wants to hear this. I don't want to hear it. Red meat does increase your risk of colon cancer. And it's not necessarily red meat, just, if you eat raw red meat, probably doesn't increase your risk, but it's really the cooking process. They found certain carcinogens or cancer-causing agents that can be formed with cooking. It's the fat in red meat, particularly grilled meats. It's the high temperature, rapid cooking. The burning of the fats can make these carcinogens, which does increase your risk. Doesn't mean you have to eliminate it completely from your diet, but decreasing it is beneficial. And we see this also with poultry too, but not as high. It's less well understood. But vegetables, you can grill your vegetables. They don't do that because it's the fats. Processed meats, and that's typically from the nitrates like sodium nitrate, sodium nitrite that you may see in the ingredients from the curing of those meats. And that's been shown to increase, it's a significant enough increase in risk that you notice a lot of your lunch meats now, just go read the package, they'll say no added nitrites and nitrates. They're not adding them to it, so they're really decreasing. Because these things, even with the red meat and the nitrates, it's dose dependent. The more you eat, the more you take in, the more it's going to increase your risk. A little bit, probably okay. We don't know what the minimum amounts are, but there are some recommendations for maximum amounts, which you can look up, but I think it's I can't even remember, 10 grams of red meat a day, but it's something that if you're sitting down to eat a steak, you probably are going to eat enough in that one meal to get your weekly allowance of it. So if you can't cut these things out completely, then do appropriate screening and you'll probably be okay. Other risk factors, inflammatory bowel disease like Crohn's disease and ulcerative colitis, those are very specific things. If anybody has a family member or has it themselves, they've probably heard of them because they can have their inflammatory processes in the colon and small bowel for Crohn's disease that causes a lot of functional problems and pain, but they both increase your risk of colon cancer. And those are treated in ways with medications to help prevent flare-ups and things. But you still need more frequent screening and checks if you have one of those. A sedentary lifestyle increases your risk. It's an independent risk factor, as well as obesity and diabetes. If you look at those, you say, well, those are all probably related. In some ways they are, but the study shows they're actually independent risk factors. So if you have a sedentary lifestyle and you're not obese, your risk is still increased. If you're obese but you're not sedentary, your risk is still increased. If you have diabetes and you're not obese, you're still increased. So those are all independent of each other, but often we'll see those go together. Alcohol consumption also increases your risk. 3 drinks a day increases, not quite, almost doubles your risk over the average population. This is a scope. This is the business end of it. Goes up there. It's just long, flexible camera. Looking at the end of it, we can put instruments through that hole. The video camera, we can irrigate through that. There's a light. This is it. We go in through the bottom and go all the way up and over. And you saw some pictures. And then on the way out, we look for things and we take biopsies or remove them on the way out. On the way out. So what to expect, or not. So basically, what everybody's mostly concerned about is the bowel prep. That varies, but everybody's heard from somebody else, or they've had an experience themselves in the past where they had bad bowel prep. They all make you have diarrhea. They all can make you cramp, flushes out your system. You can't go under anesthesia for that part of it. Go lightly or co-lite, the big gallon jug, is really the worst one. Most of us don't use that one anymore. Most people can't get it all down. A lot of bloating and nausea. It works really well. But I use magnesium citrate. It's another liquid laxative, but they're 2 10-ounce bottles and a few laxative pills after that to finish it. Most people tolerate that, but there's more gentle, prolonged bowel preps, like 2-day preps with Miralax. There's a pill prep. It's 30-something pills you have to take, so some people have trouble with it, but there is a pill prep. And then some places, you get to go to a spa next door, and they put a hose up and do a colon cleanse on the table and flush you out, and then send you next door and do the, I think there's a place in Jackson, maybe even somebody in Martin who does that. We don't really have that set up here. And for me, I'd rather be at home and drink some stuff and then show up and go to sleep. But some people love it. And so there's different options out there, but I've heard that. But there's different options for bowel prep. But if you get through that, that's most important because you need to be clean so we can see. You usually get sedation. It takes, so you get to go to sleep for it, but there's no breathing tube in. It's not general anesthesia. It's pretty low risk as far as the anesthesia goes. There's no gases, but you can't drive that day. Get the ass out all the time. Don't drive because you're under the influence technically, even though it's short-acting anesthesia. A few hours later, most people are saying they can do anything they want. It takes about 20 to 30 minutes, and there's some variability in there, and that's how long the anesthesia is. You come in before, and there's a little recovery period, but you're asleep for about 20 to 30 minutes. Could take 15 minutes, could take an hour in some cases. There are some people who have a ton of polyps, or they have a very difficult colon to maneuver through, and it just takes longer. Rarely would it take less than 10 minutes. If it does, you've either got a part of your colon removed, so it's very short, very straight, or you may not be getting a good examination. And there's some studies out there looking at how long it should take, but to get a good exam. But 20-30 minutes is average. So complications, most commonly, and these are really side effects: bloating, some cramping, sometimes some nausea. Passing of blood, that's uncommon. Usually it's just a little bit, especially if you take polyps out. But occasionally you can have significant bleeds, particularly if you're taking blood thinners. So we want to hear about that if you do. But bloating and cramping are most common, and a lot of that's from the gas we have to put in. We have to fill it up with air, blow it up like a balloon so we can see behind folds and turns and things. And we get a lot of it out, but there's always some left. So that, after a colonoscopy, the gas is not the bacteria's fault, that's my fault. So at least for that day. After that, it's yours again. Perforation, that's the most serious potential complication. That's the stories you hear about. A lot of people know somebody or have heard of somebody that have had that happen. I guess the positive side of that, not positive to have that happen, but the more you hear about that, that means there's more colonoscopies being done. It's just a numbers game. That means we're screening more people. But it is still low incidence, less than 1% of all colonoscopies. It's really reported about 0.03 to 0.7%. Depends on where it's being done, who's doing it. That does make a difference. All right, so how often do you need colonoscopy? So average risk person, her scope or index scope at 50, and then repeat it every 10 years if it's normal. So it's not every year. Of course, you do get colonoscopies sometimes for symptoms. If you have any symptoms or any problem in the interim, or even before age 50, it may be recommended you get a colonoscopy to investigate that. But strictly screening, age 50, every 10 years if it's normal. If you have that first degree relative, so parent, sibling, child, with colorectal cancer or polyps that you're aware of, first scope at age 40, or 10 years before the age of the youngest case. So if your parent was 55, you still need one at 40. If you had somebody, a first degree relative that was in their 30s or 40s, you'll need 10 years before that. and that does happen. And then in those cases, you repeat it every 5 years if it's normal. If you get your first one at age 40, and that's normal, you need one at 45. If that's normal, you need one at 50. So you're on the 5-year plan, not the 10-year plan, if you have that strong family history. If you personally have some polyps found, after the one after you have the polyp, you're probably going to need another colonoscopy in 3 to 5 years. Typically, it's going to be right at 3. Sometimes it's less than that if it's more advanced. But so basically, you can look forward to more frequent ones if you have polyps. And then when you have another normal one, then you go to every 5 years. So if you've ever had polyps before, you need one every 5 years. That's probably a lot of information, but in general, just high fiber diet for routine maintenance and adequate water intake, which everybody says 8-ounce glasses of water a day, 64 ounces. That's good. It's hard to do, but if you can do that, great. At least get close to it. Infrequent use of laxatives or antidiarrheals, if at all possible. But fiber and water first, and then you can try some other things if you need to prevent diverticular complications. High fiber diet, and then it's okay to eat your nuts and seeds, tomatoes, strawberries, those sorts of things. You don't have to suffer anymore. Prevention of colorectal carcinoma, the healthy lifestyle habits. I talked about some of those risk factors: alcohol, smoking, obesity, sedentary lifestyle, and a high fiber diet. And then for screening and prevention, if you're able, those other tests in general, these days we more do them for people that aren't a good candidate for colonoscopy or for some reason can't undergo it or absolutely refuses to. Then you need to do one of those other screening tests with the understanding that if something shows up positive, you may need a colonoscopy. And then, of course, that's what I said. If it's contraindicated to a colonoscopy, those stool tests and imaging. And that may change with time. As we get better at some of these stool tests and we can detect things earlier, we may end up something like that Cologuard maybe, that then we recommend everybody get that, and only those people that test positive, get the colonoscopy. Right now, still colonoscopy is the gold standard because we can detect, screen, and we can treat it and prevent the colon cancer. We find those little nice looking polyps instead of those big circumferential bleeding angry cancers.